So we'll execute a shift in front table, and I'll invite Dr. Barr and his panelists for our first panel this morning to come forward. And Barbara introduced Hugh as an icon in interprofessional education and the evidence about interprofessional education. And so it's a thrill to have you moderate this first panel for us this morning. And I would identify for folks that behind your agenda, you will find the biographical sketches for all of the speakers, and that will allow us not to have to recite them for each and every panel. Thank you.
Thank you for the tip there, not at length to introduce speakers, because quite frankly, the three that I would have to introduce would take the whole of the time, and they would have no opportunity to say what they have come to say. So my introductions will be extremely brief. May I first of all presume to speak on behalf of those of us who are guests here, guests from beyond the United States and North America, guests who I think would see ourselves as representing the wider global interprofessional family, an extended family, rapidly growing, many younger members of the family born in the last few years, and you are part of it. And above all, I hope, in private conversations, and I look in your direction, Patrick, that I'll have opportunities while I'm here in these 2 days to take further some of the discussions we have had elsewhere about building bridges so that we do truly become one family. This is a hugely significant occasion. Thank you for inviting us to take part in it. Chairs, moderators have self-denying ordinances. It is not for me to say anything further other than to do the appointed task where Patricia has trained us all scrupulously down the telephone line in the last week or so. The theme for these three presentations is clear from the program. It's to address objective 1, to derive principles and lessons learned about initiation and, critical words, sustainability of IPE and how IPE's success is measured. We've got 3 presenters. Margaretta, we've lost you. Come here. We've got 3 presenters from 3 different institutions, 3 different continents. I think, and I have the advantage of having seen their slides in advance, exploring variations on a theme. I hope not an enigmatic theme, but one that comes together. And what I'd like you to think about as you listen to them is not only the particular questions you want to feed back to each of them, but where the similarities lie in the differences in what they're saying. What are the points of comparison and the points of differences which we pick up and take forward as these 2 days progress? So without further ado, and reminding them that we have been terribly carefully trained about sticking strictly to the timetable, I'm going to ask first Mark and then Dawn, who's up there. Hello, Dawn. Can you hear us? She's waving, so she can hear us. That's something. Mark and then Dawn, and finally Margaretta, each to speak within the confines, and boy oh boy, it's tough, of 10 minutes, allowing time after each of them has spoken for direct questions and points of clarification, not opening the discussion, but hoping, Lucinda, that will then still leave enough time to pick up some of the threads that can be woven through that connect those presentations. So can I say, first of all, Mark Easton, the one member of the panel whom I've not met before and can't count as a friend, at least not until today, but particular pleasure to have you here from all the way from Colorado, and we look forward to your presentation.
Thanks. Thank you, Hugh, for the introduction. I want to start with a couple of points of caveat. My biggest concern presenting this is it may appear to be an end state in terms of our IP program, and it's very much a work in progress. It's the work of a lot of people who I'm representing, and it also represents an investment of others in our work, including the Macy Foundation, who really catalyzed our ability to do some work at an institution that's quite committed to this. I want to touch just on 4 themes. I would point out that the evidence behind what I'm going to talk about is largely observational and experiential. I hope 2 or 3 years from now we'll have some different data to present, but this represents the conclusions and the sort of principles we've derived from trying to do this. The first has to do with matching competencies with developmental readiness in the learners. The second, some tips that we've developed for teaching and learning teamwork and some of the challenges therein. Some opportunities to optimize instruction and the efficiency of our instruction. And then what some people have alluded to, some of the challenges with assessing this and the way we've dealt with that. I want to start just with a thumbnail of our program. Ours is longitudinal. It involves 6 different health professions. It starts within a couple of days of when they arrive, and they're actually placed into interprofessional teams that they maintain for 2 years. That first 2-year program, there's a bioethics course that they participate in as teams, and then a course that is new that we call Fundamentals of Quality and Collaborative Care that is largely focused on teamwork and communication. The students, so this program is for students, some of whom are going to be with us for 4 years. So for example, medicine, pharmacy, dentistry, some who are with us for only 2 years in our accelerated nursing program. And so all the students get all these elements, but exactly when they get it and where they are in their training varies. So for students who have become a little more mature and are progressing into more clinical experiences, we have a simulation program that's the underlying curriculum is based in team steps. They go to our simulation center and spend a half day there doing a set of simulations, and we have a menu that allows almost any permutation of professions that we've got to be accommodated with the simulations we have in our sim center. And then the biggest, and so I should say these first 2 parts are required. We have 700 students per year participating in that. The third part is still in pilot phase, and we don't have the capacity to put all our students into that. But our goal really is for students to integrate what they've learned in these earlier pieces in authentic clinical care settings and to develop the capacity to do that for all of our students. I want to talk first about competencies in learner readiness, and I'm going to take you right to the small font, which is the challenge that we've found is that when our students walk in, they want to talk about roles and responsibilities, and yet they're completely undifferentiated. And if you bring up some of the challenges that are faced in interprofessional collaboration, they're somewhat incredulous that it could even happen. They like each other, they like being together. The mere idea that they're going to differentiate is difficult for them to think through, and the fact that differentiation could lead to some challenges in communication, or that as they are professionalized into their tribes, that they may take their approach to ethics and values somewhat differently, and that may lead to conflict. And so because of that, we actually start our focus on teamwork and use that as the organizing idea behind how we get the students together and approach it that way. As the students then get into clinical settings, they start to see, in fact, some of this differentiation. and we feel it's easier to begin to deal with those different competency domains on an equal basis. One of our other discoveries is that there are a number of different group learning models out there, and yet they're not equal in terms of how much teamwork is required. When we talk with our students, they say, oh yes, we learn in teams, we've done it all the time. But in fact, when you talk about their experiences, they learn in groups. They've not necessarily learned in teams. The models I've got listed there with some of the challenges. One is the traditional model of the facilitated discussion. So the students go out, they read something, they come back and they discuss it, usually with a faculty preceptor who serves as the referee. And the goal there is that everybody speaks, everybody's heard. But generally speaking, the group doesn't necessarily have to make a decision. And if they do have to make a decision, the stakes are fairly small. The second are group projects. So you give a group of people a term paper that they have to write together, and I write the first paragraph, and you write the second, and you write the third, and then we sort of merge it together. And in fact, that's not teamwork. It's not collaboration. And generally, the students are not invested in the product. They don't feel like it's read, which it's usually not, and it's very difficult to evaluate or to evaluate somebody's contribution to it. Problem-based learning, we found is certainly a stronger methodology. We've had some challenges with that in the sense it's still hard to actually measure the contribution of individuals, and it's also hard to measure or compare the performance of one student team to another and using the PBL model. It's also very difficult, or we found it difficult to find problems that are amenable to this learning method that all of our students embrace and are ready for equally. We were very attracted to Michelson's team-based learning model, but again found the challenges, and I don't know how familiar you are with the model, but much of the work the students do is ultimately not accessible, that they can qualitatively compare their outcome with another team, but their performance is not measurable, their process is not really comparable in that regard. So the way we've approached that is we came up with a set of principles for what we consider optimal conditions for learning about teamwork. One is the requirement that the team is actually the unit of learning and the unit of work. And we prefer the method where the teams, their goal is important enough to them that they do not need a faculty preceptor. They will not have a referee when they're in Alaska working out in a small rural clinic. They'll need to work those things out themselves, and we feel it's important to create an environment where that dynamic's true in the learning environment. That the learning activity actually requires collaboration for success, that the activity centers around some form of group problem solving, that unlike the group term paper, the activity can't be easily or efficiently accomplished by a single individual or individuals working in parallel, and that the team performance ultimately is measurable. So if I'm on one team and you're on another, at the end of the learning activity, we can compare how we did in a standardized, objective way and know that your team performed better than mine. Also, that more effective collaboration actually improves that measure of team performance. So the method that we've used borrows both from team-based learning and problem-based learning. We have multiple teams together, so imagine a room this size with 8 or 9 teams and a single facilitator at the front of the room who's the timekeeper and directs their activity. The teams are working in parallel to solve a multidimensional clinical puzzle in which they're identifying potential harms and process errors. They're limited by an hour. At the end of that time, their work is done. It produces a score. And then the debrief actually focuses on what they did. So how did they get to their answer? And we had an example a couple of weeks ago. We got to the end. The team scores were posted. We started the debrief, and one of the teams raised their hand and said, our score was the lowest, so I think we need to go first. And they started talking about what they'd done and what they were planning on doing differently the next time. And that's the dynamic we're trying to foster. Our hope and our goal is that this experience creates a language and a set of experiences that they can translate into clinical settings and that they have a richer and more sophisticated understanding of what it takes to effectively collaborate. I want to mention just a few discoveries we've had. One of the most expensive things we do is our simulation. And our Sim Center is constantly under pressure to reduce costs and has come up with some ways of doing that. When we looked at where our utilization was, we were spending a lot of time, repetitive faculty time, doing orientation and introduction. So we've moved all of that into online and reduced the number of faculty hours that are required, so the students do this ahead of time. We also had a model where we had a standardized patient and a faculty observer preceptor in every simulation experience. And what our Sim Center did was actually compress that, and our SPs now actually lead the debrief. And then, as I mentioned, we have multiple scenarios to accommodate different permutations of professions. One of our other goals is to try to make it workable to have students doing IP learning in clinical settings. And given the daunting task of trying to train every clinical preceptor to be an IPE preceptor, we've adopted more of a hub and spoke model where we will have a single preceptor who will actually precept multiple teams who are working in different settings. So when they're in their setting, they may be working with their profession-specific preceptor, but then they come together for a process preceptor who works with them on that. The second goal we have is to try to increase the value of the learners to the system. We have two models where we feel like we've been successful in that. One of them based at Colorado Children's Hospital, where our students are actually integrated into the process improvement processes of the hospital. So they're actually gathering data as they learn for the hospital, and it's actually reduced the hospital's cost to do what they would have to do otherwise. The second is we have students, teams that volunteer to have students come in and assess their teamwork. The students are trained in how to do that, and then they go out and actually evaluate the teamwork of the teams and then provide these clinical teams with feedback. And our pilots with that have actually gone remarkably well. The final thing I want to touch on is this issue of how do you actually assess collaboration. And our principles are to be valid and reliable. It has to be multi-source. It can't be a single person. It can't be a single point in time. It needs to occur over multiple points in time across multiple settings. And it needs to be against a standardized rubric, which is quite difficult to accomplish. I know the ABIM is working on some of this as we speak. We've adopted a program from Purdue, which is called Academy. And you can see the acronym there. It's a fairly simple web-based model that allows a process of self and peer evaluation. So if we're on a team, I would at the end of a learning activity, I would assess myself in these 5 dimensions. My team members would all assess me, and I would assess them. And then at the end of that, we're given a single point of feedback where you see this data collated together. And our hope, we're just beginning to start the statistical analysis of this, is to be able to use this and compare it with the team performance scores we're getting in other places, and actually to measure our students over time. And that's the end of my talk.
Thank you, Mark. You make it sound so easy. Do you in this continent use the expression, what are the wicked questions? Can I ask you to identify what is the most wicked question for you in carrying all that program through? It's very impressive. Then others will have a chance.
The list is long. I don't know where to start. I think the most vexing thing for me is the question that has come up already a couple of times, which is how do we know we're successful? We're doing all this to teach these skills. How can we actually know that we've imparted them to our learners first, and how do we know that's actually impacted patient care?
Okay, and we'll hang on to that for the rest of the 2 days.
Two related questions. Could you just give examples of what are some of the things that the teams worked on? And also, who are the facilitators? What discipline, and are they also teamed from different disciplines?
So the first case our students get Is that on? Okay, I'm sorry, I've been turning it off. The first case our students get literally starts with the scenario: Mr. Garcia is going to the dentist today. By the end of the week, something potentially catastrophic will happen to Mr. Garcia. Your job is to figure out all the potential things that could happen. And then they're given the dental chart, which has some medical information. They do what we call team fitness challenges, which are some tasks in situation monitoring. And then they get more information after they've completed that. And then, so there are actually 3 different additional packets of information they get. And there are latent errors, process mistakes, things that happen in there. And the team has to sort through all of that, come up with all of the possible things, and they get a score for that. Our preceptors, so we actually have 7 health professions on campus: medicine, pharmacy, dentistry, PA, PT, nursing, yes, forgive me, and then we have public health, and all of our students except for public health right now participate in that, and we actually have preceptors from all those disciplines.
Time for, I think, perhaps 2 questions. Yes, please.
Very nice presentation, Mark. I appreciate it. I was intrigued by the efficiency of the hub and spoke model. The hub and spoke model. It's on. Maybe I'm not close enough to it. I was intrigued by the efficiency of the hub and spoke model, which is why I think you employed it. But how do you deal with the dissonance in the student's mind coming from a practice environment that is not practicing IPE? How do you sort of deal with that when they come back to the facilitation, to the home base, so to speak?
Right now, I don't know that I have a simple answer for you, Malcolm. One of the messages that our students get from the day they start to the day they finish is that you're going to be trained with a set of skills that are necessary for transforming care, and that whether you want it or not, you're going to play a role in that transformation. And you are going to learn by negative examples as well as positive examples. One of our goals is to help you keep a laser focus on those positive examples and to be an agent of change to create them.
I think the questions are running away. If you make them very quick, and perhaps, Mark, if you can try and respond to them together rather than separately, if that works out. But over here, and Matty, and somebody behind, and in the center.
Very informative. Mark, could you talk a little bit more about continuity? How long is the team together, and what's the period of continuity with a given facilitator?
Do you want me to hear all the questions first, or?
Well, if you could.
So 2 years that they're together.
That's easy, okay.
Okay, yep.
And Matty?
My question focused on the work that the students do in the hospital setting to observe and give feedback to practice teams. That's a very tricky kind of process to engage in, and I'm wondering how you manage to engage teams in being open to that kind of feedback, and how you instruct the students to manage that.
We sent out an invitation for teams who wanted to be evaluated as teams. So we got volunteers who were interested in getting this feedback. Interestingly, even with that, we ended up with one of our surgical transplant teams who, when it was over, said, you know, we probably don't want to hear what they have to say. So
Behind and then in front. Then that's the lot for this bit.
Thanks, Mark. That was great. One of the things you talked about was that first preclinical exposure that they have to each other as students in individual professional programs. And there is some experience from projects done by Macy that we see people come into the professions with already preconceived notions of their roles in the hierarchical structure of the professions. Are you finding that, and how do you address that? And are you seeing a transition out of those hierarchical preconceived notions?
I think it's too early for me to say that I can say with confidence we're seeing a difference. One of the things we do in their orientation is, before the orientation day, we have them, there's a trying to remember the name of it. It's a survey. It actually came out of the UK of stereotypes, and are physical therapists sporty, for example? And so we selected a set of those questions and had the students answer them, and then we actually tossed this back to them and showed the skew of, and in fact, on these, on these very odd things, they do just carry these stereotypical thoughts, and so it becomes part of our dialogue. But I'm not convinced that we'll see in a few years whether we reduce some of that or not.
Please.
We've identified, as a follow on Malcolm's comments, I think we've identified the sort of the confounder in interprofessional education being the fact that the clinical settings in which we put our students are not yet typically very emblematic of teamwork and of interprofessional collaboration. I just was curious to know, in your own setting, how you would evaluate the learning environments that your students eventually go into in the real clinical world. How far advanced is it with respect to the kind of learning environments that we'd like to see?
One of the things that we set out to do early on was try to identify bright spots and exemplars, and we found actually it's one of those things, it when you see it. It's fairly hard to get to. In my mind, some of the more convincing work that I've seen in this is Brian Sexton's work, and some of the things they've done looking at using the culture of safety surveys, and that where those scores are high, you tend to see very high levels of collaboration and low levels of process errors or things like central line infections and other measures that we would have. We have not done that survey in particular, and I also think that doesn't necessarily translate to the optimal. It may be a very optimal clinical environment for care. It may not be an optimal learning environment for students, depending on who's there. So that's still something we struggle with.
Okay, there we must pause. Mark, thank you. That's a great start, I think a flying start, and really a very positive note, which I hope will carry through not only this, but subsequent sessions also. Dawn, are you hearing us? We can see you. Can you speak back to us to make sure we're working?
Hi, Hugh. I can hear you, and I hope you can hear me too.
That's just perfect. And if the accent doesn't sound quite what you expect from Australia, there is a simple explanation. Dawn, like me, comes from the UK, and if you work hard enough on it, from the same region of the UK in the accent that we both use. But Dawn, lovely to have you online, and thank you. Spring is coming in Perth, and I guess it's good this morning. Or not this morning, whatever hour it is.
Well, it's the evening. It's now 11 o'clock in the evening, and it's actually been quite rainy and blustery today, which is very unusual for Perth. So thank you very much for inviting me to contribute today. It's a great pleasure for me to be involved in this workshop.
Good. Well, we're looking forward to hearing a lot. As you know, like you, I'm a not quite so frequent visitor to Curtin, but for the benefit of the group here, Curtin is one of the new and immensely energetic, forward-looking universities in Australia. I think I'll risk to say, driving the agenda throughout Australia for IPE. And Dawn, since she moved out from England, has had a key role in helping to that carry forward. So over to you, Dawn.
Thank you again, Hugh, and it's a pleasure to be here. I'm going to say thank you to Megan as I begin, because I'm hoping that she's going to help me in the presentation of the slides that we have for you today. As Hugh was saying, I'm speaking from Curtin University, which is in Perth, one of the most isolated cities in the world, in Western Australia. And Australia has been very fortunate in that it has been looking at interprofessional education nationally and has been funded for a number of projects. So there are a number of universities that are taking forward interprofessional education and interprofessional practice funded by Health Workforce Australia and also from the Office of Learning and Teaching. One of our problems, however, is where are we going to go when that money ceases to exist, and how do we ensure sustainability of the work that has been undertaken? I'm going to talk to you about Curtin's perspective and how it's developed over the last 4 years. And I'm going to take you through what has been developed, but concentrate on the patient aspects or the client aspects and looking at new models of interprofessional healthcare and new and old evaluation tools. It's true to say that Curtin University has been undertaking interprofessional education over the last 4 years, and I was interested to hear Barbara's presentation earlier today, which encouraged us to look internationally at what had been developed and to learn from practice internationally. That's exactly what Curtin did when it first started out. It looked at what was available internationally, what models were available, what tools were available, and tried to integrate those into the context within Australia. So I'd like to move to the second slide now, please. The second slide is a cartoon, but I think it depicts the situation that we're all very familiar with, that we need to integrate our services and to ensure that we don't have this sort of experience for our patients, that they are see themselves as going from one profession to another and addressing the same questions. We want to offer an integrated interprofessional service, and with that in mind, also always concentrating on the client and the patient, Curtin University have developed an interprofessional education capability framework, which is on slide 3 for you today. This framework actually exists throughout the curriculum and also extends into interprofessional practice. The curriculum actually starts with the first year. We have an integrated first year curriculum, which builds on this model of ensuring client safety, but we have 23 professions actually undertaking that interprofessional first year. We build on that in the second, third and fourth years for each of the programs by having 1 unit per profession, 1 unit for each profession, which is integrated in each of the subsequent years, a number of workshops, simulation activities, and of course, the placement activities. The ICAT that we've developed is an interprofessional capability tool. We took the models from Sheffield Hallam University and Toronto University and again applied it within the context of Australia using our interprofessional capability framework and have a capability tool which we use in practice. We move to slide 4. We now have 23 interprofessional placements which span the range of different conditions that we would find our clients in. So we start with early interventions. We have 6 schools in which we're offering interprofessional placements, working with children to ensure that their health needs are looked at that early stage, and therefore improving their chances of actually being able to learn within those school environments. We span all the way through to aged care settings when we work with other universities in a Brightwater setting, which was one of the earliest placements that we established. And we also have a training ward, which again was built on the models from Linköping University and St George's University. So I hope you get a flavour of how we've utilised other people's experience and actually integrated those into our services. We don't have medicine within the university at the moment, but we are developing a medical curriculum which is built on interprofessional education, so we're taking it through to that profession. And as I indicated earlier, we're getting a lot of support from the government, and I'm sure you'll recognise the lady in the bottom right-hand corner there giving her support at one of our early intervention centres. We move to slide 5. We have an interprofessional clinic actually on campus. So we have, which works on a hub and spoke model. We have a clinic on the campus and also a clinic within the city of Perth. And we offer a stuttering clinic, a hand therapy clinic, a musculoskeletal clinic, a wound education centre clinic. All of these are interprofessional clinics, obviously having two or more professions actually studying together with a concentration on the client and the patient. I'm going to move on now to slide 6 and tell you about the medical centre that we're working with in an aged care setting. This is one of our latest developments, and we here actually are trying to ensure that we have an interprofessional integrated service. Now, just to tell you a little bit about the service as it operates within Australia, payment is given to GPs for the service that they provide to the client, and they have to complete a care plan to send this off, and then by bulk billing they are paid for that client's service. But they only have a limited period of time with the client, as does any other allied health profession. And we feel that we don't always ensure that a rounded experience for the client is given, that all aspects of the client's condition is given. So by working with the GPs and other stakeholders, we ask them what sort of thing would benefit them in terms of the service that they were able to offer to the client if we were to introduce our students into that clinic setting. So on 2 afternoons per week, we lease the medical centre premises, and we ask the clients to either refer themselves from the aged care setting via the GP or via another health professional to the student-run clinic. We do a holistic lifestyle assessment, which includes a cognizance assessment, a continence assessment, a falls assessment, and a medicines review assessment for the clients that are coming. That assessment forms the basis of a draft care plan, which goes with the client to the GP or the allied health professional, and then that is signed off, enabling the GP or other health professional to pull down the funding that is available to them. The GP also has the option of pulling down a further funding for another 6 sessions for, say, a physiotherapist or an occupational therapist, and we are working with them again to integrate that into to services that the students can provide in the future. So perhaps a student physiotherapy or hand therapy clinic could be undertaken to dovetail in with the other sessions that the profession is operating. We move to slide 7. As with all developments, we want to ensure that a sequence is followed, and we take our students through this sequence by giving them an orientation. They review the client's notes. They look at visiting the resident or ensuring that the appointment is made for this appropriately to when the students will be available. They consult with other health professionals, if appropriate, when they're seeing that client, and undertake the interprofessional assessment. We do ensure that the students are assessed in terms of their capabilities. You'll remember the interprofessional capability framework and our ICAT tool. So this assesses the students' interprofessional capabilities as well as the students being assessed with their profession-specific assessments. And we've also undertaken an attitudinal test. A lot of publications, as you'll be aware, actually look at the changes in the attitude of students when they're working in professional settings. If we move to slide 8, this shows some of the data that has been available using the interprofessional socialization and value scale, the ISVAS as it's abbreviated to, and the changes that occur within that in terms of attitudes towards the ability to collaborate, valuing collaboration, and the comfort in collaboration. To that tool, we added some qualitative assessment tools to enable the students to actually give their own comments in terms of their experience. And it was interesting to note that the students indicated that they were more likely to work in an aged care setting as a result of their experience. They valued the experience there, and obviously We do want our students to want to work in aged care settings for the future. And they understood much more about not only interprofessional education, but integrated models, how they worked with other professions and actually ensured the client's information was passed on between the professions. If we move to slide 9, we were obviously undertaking assessments on the client in accordance with their needs. So the medicines review was undertaken, a cognizance assessment, a falls assessment, etc. And with operating in an aged care setting, a lot of these clients had multiple needs, complex chronic conditions, which were being examined by our students. And I have to emphasize again, obviously these students were operating under supervision by referral. So there were complex conditions that they were actually looking at. And slide 10 indicates to you that in terms of the attitudinal change, indeed we were very concerned that because of the complex nature of the clients, the students may be a little put off in terms of the integrated and interprofessional service in which they were able to operate. But indeed what we found was the students enjoyed the experience of working with clients with more complex needs because it brought out the interprofessional nature and very much centered on those clients' needs. This was a trial, and as you've heard earlier, there are a number of professional settings that we're actually operating with our clients. And at Curtin, we feel this is where we should be working in an interprofessional way. We should be looking at interprofessional practice and what underpins good interprofessional practice and improving services. And in that way, if we're operating with our colleagues actually working within the health service, we're actually developing new models of care with a concentration on the client, and by that way we will be able to gain sustainable methods of working for the future. That concludes my presentation, and I'm happy to take questions as is shown on slide 11.
That was
Thank
fantastic. And the technology from Australia to here is working just fine. I'm not sure how easy it works when it comes to question time. We have time for 3 or 4 questions only, with fairly brief replies from you, please, Dawn. Could I ask the questioners to identify themselves by name and institution for Dawn's benefit? And Dawn, if you're hearing them, wave back to them before they go any further. And if you're not, signal in some other way. Please.
Dawn, this is Jordan. Hello, Dawn. This is Jordan Cohen. I'm one of the co-chairs of the forum. Thank you very much for your presentation. I was curious, and I'm going to ask you a speculative question. You noted that Curtin University does not have a medical faculty yet. We've been talking a lot about the hierarchical culture that typically dominates our institutions and forms a potentially strong impediment to interprofessional education. I'm wondering whether you think the absence of medicine in your environment was a facilitator to your program.
Does it help not to have medicine around?
I'm not sure that it was a facilitator to the program. Particularly when we were working with the placements, we collaborated with universities, the University of Western Australia and Notre Dame University, which do have medical programs, because we were conscious that obviously in any setting, placement setting, and any client setting, that those professions would be required. And so therefore, I'm not sure it was a benefit to us. In fact, I believe it was a disadvantage that we needed to go to other universities to ensure that we were looking at the client's needs holistically. Certainly, in terms of the curriculum that we're developing now for the medical curriculum, it's very strongly interprofessional, and the feedback from the policymakers, the funders, is that they are very warm to the idea of interprofessional education as part of the medical curriculum program.
FF.
Thank you so much, Don. I'm Afaf Milis, and I'm one of the other co-chair for this forum. One of the things we talked about here is how important is the culture of a university in promoting or hindering the development of interprofessional education. Could you tell us what in your organization, what 2-3 things helped in the development of what you are doing, and 1 or 2 things that might have been hindering it?
That's a very good question. I certainly believe that had it not been for the leadership within the university and also within the Department of Health within WA, that interprofessional education would not have been started. And so leadership is absolutely critical. And we know from experience where leadership has changed in universities and interprofessional education has been started and then the leadership changes, then often it doesn't continue. So that was key. As I've indicated previously, I think another key point was that Curtin University looked elsewhere internationally for models of how it would develop both its curriculum and its practice, and indeed the evaluation tools that are being used, and built from the strength of others, and in a sense plagiarized with pride in terms of what was going on elsewhere, and then ensured that we put it into the context of Australia and indeed the context of Perth. So I think that those are the 3 things: the leadership, the looking internationally in terms of the development, and ensuring that it's context specific in terms of what is being undertaken.
Dawn, thank you. I'm hoping we'll have some time left for a few more comments and last-minute observations from the 3 of you. So do please stay online, but that's tremendously helpful and really begins to carry the theme forward. Can I, for our 3rd presentation, introduce Margareta Wilhelmsen. We pronounce it properly in Europe. You might say it some other way, but I think that's correct. Margareta is the last in a quite long line of distinguished leaders at Linköping University in Sweden, where I won't say that, although sometimes it is said that undergraduate IPE began, but certainly a most distinctive model began, and one which has been systematically developed and reviewed over the years and followed. All roads may in Europe lead to Rome. I think the metaphor might be better to say Mecca, which isn't quite in Europe. But many people, and I'm one of them, have gone to Linköping and learned a great deal from Margareta and her colleagues. The second best, but it's still a pretty good best, is to have you here in person.
Thank you very much, and I'm very pleased to be here. So I am Margareta Wilhelmsen from the Linköping University, and I have been working with interprofessional education for more than 20 years. So my presentation perhaps being a little bit focusing on other things. I just briefly going through our curriculum, the IP curriculum, and then I am focusing on interprofessional competence and then some evidence from our university. So, with,
Sorry, you want, yeah.
Okay. Here is the Linköping model, and we are thinking then that interprofessional learning is a process over time. You can see the interprofessional competence on here, and you can see the educational programs, the time of the process in education on basic line. And we are starting with an 8-week course called Health, Ethics and Learning for all the students in our university. 507 different programs, from doctor, nurses, occupational therapists to biomedical scientists. And in this first course, we also introduced problem-based learning. A very happy marriage, I will say. And we are working to give the students a platform, sort of together knowledge about health, ethics, and learning here in the first step. And then in the second step, in the middle of the education, we have a 2-week course today called Health, Ethics and Learning Part 2. And here the students are doing projects together in interprofessional teams in the health care in the hospitals and in the primary care. And the last part, all the students have a 2-week placement at a training ward where the students are taking care of patients with one supervisor. So they are having all the responsibility for these patients, and they really think it's very, very fun to work in this training ward. So this is a little bit about our curriculum. And we're thinking that interprofessional learning is leading to interprofessional competence. And I have looked at 5 important documents from the United Kingdom, from US, and from Canada, and summarized them. And the domains I found was very important is teamwork and group process, reflection and documentation, communication, and a general common knowledge base, and ethics. So here are here you can see the references, 2 from the United Kingdom, 2 from Canada, and 1 from the United States. So how can we think about interprofessional competence? First, I want to say that reflection by John Dewey first described this. And in Sweden, we are thinking about that reflection is thinking in a deeper level, taking several perspectives on a problem. And then thinking about Donald Schoen, who have written the book, The Professional, Reflective Professions. And he is telling that you have to reflect on acting. And I also want to introduce metacognitive thinking, or models. Nurses and occupational therapists daily use these models. They are working in models like Betty Newman's taking care models, or Kielhofer's occupational therapists models, thinking in a higher level about thinking of my thinking. So I would like to say that to be very successful in interprofessional work, you need such models to underpin the interprofessional work in those teams. We need, for example, models such as problem-solving process, also introduced by John Dewey. And we also need models for teamwork, and we need also acting professional models, and I'm coming back to that later on. So, here also some contribution to interprofessional competence that have been my area in my research, and thinking about shifting perspective. We have to shift perspective if we are going to understand a doctor or a nurse perspective or an occupational therapist perspective. We need to learn from each other, about each other, and with each other. And my supervisor, Lars-Ove Dahlgren, he introduced in London this concept, the centering, and he borrowed it from Jean Piaget. And he said, children in a special level, shifting from being egocentric to being decentric, taking another person's perspective on the problem or the question or whatever, the phenomenon. And then the child is being more empathic when shifting perspective. And also thinking of George Herbert Mead, and he's saying, what glasses have you on when you are looking at the phenomenon? Have you the economic glasses? Have you the biologic? Or have you the caring glasses on when you are looking on the phenomenon? So here is a model we are using in Linköping, a metacognitive model of professional acting. And I'm just briefly going through it. You have a systematic base of theories. And if you have the nurse and you have the medical and you have the occupational therapist, you can build on and have a bigger base of theory. And the same with a set of methods where you can have methods like Betty Newman, and you can have occupational therapists models, and you can have methods to measure hemoglobin. And starting in the goals, where you can have the question, why and how and when are we going to do this acting? And in the other end, you see the professional acting, and there you can put in the patient. And then you have the reflection going round here. You see Donald Schoen, reflection in action and on action and for action. And the most important part in this model is in the middle, your personal profile. Are you ready to work interprofessional? So this is some evaluations we have done in our university. Every year, our medical students are asked 8 questions about how the education have prepared them to be doctors. And we were just interested in one of these 8 questions. And this question was, have your education prepared you to collaborate with other professions? And Since 2000 to until today, our students in Linköping in a higher level saying that they have been prepared to work together with other professions. Then another study we have done, we have asked about 700 students from medical and nurse programs in our university and Karolinska Institutet in Linköping, in Stockholm, and we used the Ripples instrument, Readiness for Interprofessional Learning. And here you can see the results. To be a woman and study at the nurse program and having early IPE, this is main factors for being ready for interprofessional learning. Being a team player. And here is the definition about the team player. So you can see, you can read it yourself. So I would like to say at last, the winner of interprofessional education must always be the patient. Thank you very much for listening to me. So that was just briefly, and here you can see my articles I have written about interprofessional learning. Thank you.
Margareta, thank you for that. And I think we have to change the program. Sorry to interfere with all the arrangements we've made. Remedial classes will be held for the rest of the day. To be more serious, for me, when I listen to Margareta, thank you. When I listen to Margareta, I'm very conscious, and I want to mention you here, Jan, that there is a continental European tradition behind this, which I think has its own evolving theoretical rationale and value base, which is distinct from the Anglo-American tradition. And just to say that that makes me particularly happy that we've had Margareta talking from that perspective. Time for just 2 questions to Margareta. Please, Melissa.
I actually have a question that could be answered by anyone. I'm from the Northwestern University in Chicago. I'm an OBGYN by training, but I'm a fellow here at the Institute of Medicine currently. And my question is in terms of pushing this field forward and assessment, I'm interested in the outliers in the negative way. So who are the ones, the students, participants, faculty, preceptors, that do not take well to these models that you're using? And are these experiences then being fed into tweaking the model and then perhaps tweaking how the faculty are recruited, what characteristics you're looking for, how the students are being recruited, what characteristics you're looking for, and how you're modulating it for the patient, depending on who they are?
So, if I understand your question, I say that it will always be subgroups working in other directions of interprofessional learning. For example, in our faculty, those who are very biological interested, for example, those who are working with molecular biology these days, they don't want us to have interprofessional learning because they want to teach the students about molecular biology, and then they got the money for the teaching. So it's so. But the students are, I would like to say, nearly all of them are very proud of to have been educated from our university. And we, in Sweden, we always evaluate as the best university for the medical students and for the nurse students.
One more question from George Thiebaud.
So thank you for all of the speakers for very insightful presentations. But Margarita, two questions for you. One is, since unfortunately not everybody can be a woman or a nurse, what insights have you gained about bringing along both the other professions and the other gender? And secondly, the very important observation you made about the importance of reflection on this. How have you been able to protect time for reflection, which seems to be crowded out all through not only our teaching programs, but even more our practice programs? What thought have you given and what success have you had in preserving reflection in the whole process? So
Yeah,
two complicated questions.
If I understand your question, I will say that we are starting with reflection from the first day when the students coming to the university. And when you are working with problem-based learning and the problem solving process, you need to be reflecting. And we always saying to the students that you need to reflect about this. You need to think on a deeper level, because you have to choose a way of what you are going to do, and you have to motivate why you are taking this way. So reflection is very central in our education.
Thank you very much. Sorry there's not more time for questions now, but this is only the beginning of a two-day meeting and endless possibilities for private discussions to take things forward, except sadly with Dawn. I want to ask each, because the time is up, of the presenters for one concluding thought. But before I do so, and while they're thinking, does anybody else, just very briefly, want to make any connection between the three presentations they've heard? Matty.
I have one, having listened to some presentations about health professions education recently in the States, and having people reflect on the protocolized way that education is being offered and practice is being delivered. One of the things that I heard in each of the presentations was how room for creativity and challenge is integrated into the curriculum. So in the presentation from Mark Ernst, there's that expectation that students will figure things out for themselves. Do I remember that right, Mark?
Yeah.
And the reflection piece really demands a deeper level of thinking and creativity. I think I just want to make the brief comment that I heard in each of the presentations room for that kind of education.
Thank you. Afafa?
I don't know if that's a theme in all presentations, but a thought has been triggered by your presentations that it's not only reflection about the different professions and taking the role of the others, Alamid, but it's also a gender analysis and a reflection on gender, because we know the hierarchies have been also gendered. So we really cannot separate the dialogue about the different professions and the hierarchies without bringing in gender issues.
Thank you. Marla?
It's actually to build on the construct of decentering, and I really appreciate the fact that you're challenging us in the U.S. to go beyond the thought that perhaps we invented all of this. So thank you very much for that.
And we'll give you the references afterwards. There's lots on it. Thank you for those comments. Can I then ask each of the three presenters for their single, underlined, concluding thought? What felt different when you listened to the other two? Did it make you think again, or did it come across as much the same?
I've been busy taking notes, actually, and I want to follow up. Actually, I wanted to use my couple of sentences to connect George's and Melissa's comments and some of what just came up. And my sense is, if you were to sort of roughly draw two archetypes, at one end you'd have the very reflective student who may be less comfortable in executive function, and at the other end you have the executive-focused student who only wants to reflect when their execution fails. And and much of our learning process is around reflection really caters to those who like it. And if you're going to apply gender stereotypes to that, that tends to be more of a feminine characteristic. And yet, we're not going to erase those preferences. And one of the reasons we adopted this model, which actually is more like a game and plays out like a competition, is it provides those executive type students a quasi-clinical setting where, in fact, if you are an overly assertive executive, you will fail and you will be forced to do reflection on action and inaction, and yet an optimal learning environment, you need a balance of those things. So.
Thank you. Dawn, have you a concluding comment to share before you go to bed?
I only to say that, that there is a lot of strength in all of the presentations that we've delivered today, and part of that strength and the strength of the conference such as this is the sharing that can go on. And, we need to share internationally and not to countries that serves the needs of the populations.
Thank you for that. Margareta?
Yes, I would like to say that it seems that we all, the presentations here are very proud of what they are doing, and we have very satisfied students, I think. It's one of...
Not always.
Yeah. Not always.
I think the wonderful thing, time and time again, in coming to interprofessional conferences, wherever it is around the globe, is the openness, and Dawn has made my point for me, and the capacity in the fierce competitive world of academe, to which most of us belong, to set that just for a few minutes on one side and to talk openly and ready to learn from others, and signaling our readiness to work together in the future. And if this opening session has contributed that tone, then that makes me very happy. Dawn, it's time to put the cocoa on and sleep well. And thank you for joining us.
Thank you very much. Thank you.
Special thanks to the panel. You've kicked the meeting off superbly. You've now earned a break where you can learn with, from, and about each other for the next, until about 11:12. And if you come back a few minutes early, we have a hot off-the-press announcement to share with you. So this will get you back in on time to begin our next session promptly at 11:15.